Good day. Welcome to our SPC WHO CC webinar. My name is Makia Majrashi. I'm a senior patient safety specialist. I'm actually covering on behalf of my colleague Heba, who is sick, all our prayers that she will get well soon. You will be hearing a presentation from Dr. Dave Meyer, who will be speaking to us on communication and optimal resolution, CANDOR in healthcare. Dr. Meyer is Executive Director of the MedStar Institute for Quality and Safety. In this role, Dr. Meyer leads specific quality and safety programs in support of discovery, learning, and application of innovative methods to operational clinical challenges. Now, moving along to our session, please welcome Dr. David Meyer to deliver the presentation. Over to you, Doctor.
Thank you, Makia. I appreciate the opportunity to join this esteemed audience today and share thoughts about not only CANDOR, as you mentioned, the communication and optimal resolution programs that we're seeing being adopted across the world, but how it plays a big effect in implementing and creating a culture of not only patient safety, but associate safety. I think as we've seen with COVID over the last 2 years, it's extremely important to not only keep our patients safe when they're under our care, but also go and do everything possible to keep those at the front line of care, our healthcare workforce, safe. And these same principles can apply to both of those accomplishments. Just to share, I have no conflicts of interest to declare as we move forward in my talk. A little background. Some of you might not have known about who the Patient Safety Movement Foundation is. I recently stepped down, but served as CEO for 3 years at the Patient Safety Movement Foundation. I still am an active board member and committee member. It's a wonderful organization. It spans across the world, as you could see. We've got close to 4,800 hospitals in 48 countries that all are working with us, using our tools, using our educational programs. Our mission is 0 preventable deaths in healthcare. We offer now almost 45 what are called actionable patient safety solutions. These are toolkits that allow you to focus in on key areas within patient safety: medication error, hospital-acquired infection. They contain all the current evidence and best practices to ensure that at your hospital, you are implementing all the right types of techniques and training that's necessary to achieve 0 preventable harm. I've included our website, and we encourage all of you to join us. Come visit our site, learn more about us and what we do to drive towards 0 preventable deaths across the world. As Makia said, I also serve as the executive director for the MedStar Institute of Quality and Safety for a number of years. I was the operational vice president for quality and safety, and now I oversee the institute, which looks at research, education, innovation in the patient safety field. You can see MedStar is the largest health system in the Mid-Atlantic area. It's one of the top 20 health systems in the United States. We have 10 hospitals, including Georgetown and Washington Hospital Center, over 30,000 employees, 1,100 residents. But what really impressed me a lot through my years with MedStar is not only do we have a specific institute for quality and safety, but we've got a National Center for Human Factors Engineering. We've got a research institute. We've got a huge simulation center. And we also have what's called the Institute for Innovation that allows us to look at things differently and to try out newer applications that maybe don't seem to be the perfect tool, but yet we find out and our teams learn how to use them effectively to save lives. I love this quote. Medicine used to be simple and effective and relatively safe. Now it is complex, effective, and potentially dangerous. I remember many years ago where if you had high blood pressure, you went and saw your physician, you got a medication, and you went home. You came back 7 days later and either the medication worked or it didn't. Today, we're doing so many amazing things. We're curing cancers we never thought curable. Invasive procedures are being done minimally invasive through robotic approaches that allow patients to go home literally on the same day. But it hasn't come without some dangers inherent in the system, infrastructure and system and process issues around communication and other applications that unfortunately has made preventable medical deaths within our hospitals one of the top leaders in mortality in the healthcare arena. So I'm going to stop here, Makia, and ask you to put up our first poll question and to see how the audience responds.
Yeah, doctor, it's effective patient safety culture includes A, transparent approach to medical error, punishing people who make errors at work, the use of high reliability tools and techniques, D, human factors approach to system and process improvement. Back to you, doctor, for the answer.
Yeah, thanks. We'll give the audience a few more seconds to respond. So in this particular question, A, C, and D are all correct answers. So I applaud that. Punishing people who make errors at work. We'll talk a little bit about that later in my talk. But we've seen that by punishing people, all they do is start hiding things from us. But good results. Okay. How do we take the poll off there? My slides aren't advancing. Makia, do you need to take the poll off or something because the slides aren't advancing?
Yeah, just go next.
Yeah, I'm trying to. It doesn't. Let me see. Sort of like locked my screen. Let me try this.
Okay.
There we go. Sorry about that. For some reason, the poll question locked my screen up. So here's a sort of an approach that many people believe. We adopted it at MedStar and establishing a true culture of safety. First, you need to use process design. And what does that mean? It's evidence-based practice. We need to follow the research, follow the literature, what's proven to be best practices, and we need to adopt it. We need to use things like bundles around central line infections and ventilator-associated pneumonias. We need to use checklists when appropriate. So process design is first. Second, reliability culture. We need to adopt the principles, the tools and techniques of high reliability science. We need to embrace a human factors approach to learning. And I'll talk about that a little bit later in my talk. We need to also engage our patients and families in our journey to zero preventable harm. They need to be partners on committees and other areas where they bring a different insight than many of us may appreciate. And then finally, where we'll spend most of the talk today on transparency. How do we embrace transparency? Those 5 things we really believe are key to creating a culture of true safety within our organizations. So let's get to candor. Candor, by definition, is the quality of speaking honestly and openly about things. And that includes, specific to our environment, medical errors, outcomes, preventable medical harm, things like that, the ability to talk openly and honestly amongst ourselves as well as with our patients and families. A little story here. The caption says, you should have seen the look on our faces when we realized that we've been looking at the x-rays backwards for the first hour of surgery. The poor gentleman has 2 thoracic incisions. I first saw this a number of years ago, and by training, I'm a cardiac anesthesiologist. I did thoracotomies and cardiac surgery and provided the anesthesia for both of those. So this case had a little bit of a personal reflection for me. The second thing also was it reminded me that when I was a senior resident, I was involved in a wrong-sided surgery. And you think about how does a team come to work one day trying to do well and heal and yet cause harm? Well, my patient was coming in for a right-sided inguinal hernia repair. We brought my patient in the room. I put my patient to sleep under general anesthesia, and I started doing my thing. I started charting my anesthetic record. I was paying attention to my monitors and the patient's vitals, and the surgical team and nursing staff started prepping and draping the patient. Unbeknownst to me that when an incision was made, because I was still looking at my anesthetic record, that the surgical resident who started the case made the incision in the left inguinal groin area. 2 minutes after the procedure started, the chief surgery attending comes into the operating room. He had been detained at the scrub sink talking to another surgeon about a patient on the floor. And as he came to the surgical table, he said, "I thought this was a right-sided hernia repair." The resident was so devastated at the mistake that they got lightheaded and almost passed out at the table. The resident was fine. The surgery attending closed the left side, went to the right side, repaired the hernia on the right side. And now, as I'm waking my patient up, he has 2 incisions with 2 dressings on them, the right and the left side of the groin. I take my patient to the post-op recovery area, and I am dreading, not looking forward to going back in an hour and discharging my patient after the anesthetics have worn off and the patient is ready to go home. I figure I'm going to get yelled at. I'm going to get just, rightfully so, asked, "What happened? How did you make such an error?" An hour goes by, I go into the recovery room, and as I walk up to the patient's bed, I see that the patient is smiling and looks very happy. As I step up to the side of the bed, the patient looks at me and goes, "Today's my lucky day." And I am totally dumbfounded. I am totally at a loss for words. And I say nothing. And the patient goes, "Yes, today's my lucky day because my surgeon discovered I had 2 hernias under general anesthesia, and I was able to fix both hernias under one surgical day, meaning that I didn't have to come back a second time and go through another surgical procedure. Today is my lucky day." And I was caught totally off guard. I never thought that that would be our reply to this patient. I didn't know what to say. I was sort of scared because of still being a resident. And I looked at the patient and I said, "Yes, today is your lucky day." When you look at the definition of professionalism, it includes all these different descriptors: being altruistic, being caring and compassionate, being accountable, respecting our patients and others. Well, in those 6 words that I said to the patient, "Yes, today is your lucky day," I violated all 8 of those definitions of professionalism. Not only was it morally and ethically wrong to lie to the patient after we had made the mistake, but almost as important is we didn't learn from it. We hid that mistake. We said, "Don't talk about it to anybody. Don't share it with anybody, because if we share it, maybe one of the nurses or another physician is friends with that patient and it'll get back to that patient." And so we kept that hidden, as we do a lot of our mistakes, because we're afraid to talk to them. There's a number of reasons why we're afraid to talk about mistakes, but we'll talk about why that's probably the wrong way of doing things. So you say, "Okay, that was many years ago. That was a one-time story." Well, no, this continues to occur. When I was at the University of Illinois, a number of years later, we had a patient who was the chief operating officer at one of our hospitals within our network. We knew the woman. She was a friend of ours. She came in for surgery. She was having cosmetic surgery. She was going to be married in 8 months and wanted to have some cosmetic work done. And she comes in the night before, and we do blood work on her like we would do any patient in a pre-op situation. And that morning, before she goes into the operating room, the surgery staff, the anesthesia staff, the nursing staff, all look at the patient's blood work and x-ray results, but everyone missed that the patient had a white blood cell count of 1,000. And I think most people on our webinar today realize that that's very low. No one notices it. The woman is brought into the operating room. Surgery goes fine. She goes to the floor. She's going to stay overnight. She has a second blood test drawn that evening. And now her white blood cell count comes back at 600. A critical lab alert triggers, and the person in the lab calls the floor to let the nurse named Mary know that this patient has a very low white blood cell count. Well, I'll tell you, no one seemed to know that there was a nurse named Mary on that floor. When we went back, there wasn't any nurse named Mary on the floor. So we don't know who took the call. We don't know if there was even a call made, but no one acted on it. The next morning, the patient is sent home. And 6 weeks later, she shows up in the emergency department of another hospital within our city. And now she is infected, septic, and 3 days later passes away or dies because of a leukemia that was undiagnosed. That hospital calls us up and says, she was just in your hospital 6 weeks ago. Did your blood work show anything abnormal at the time? Because it's very rare for this type of leukemia just to come on that quickly. And we looked at our blood work, we looked at her chart, and we found out that not only did we miss it once, we missed it twice, and we were devastated. We wanted to apologize to the woman. We wanted to her family. We wanted to share that we had made this mistake. And while we don't know if we could have saved her, we sure wouldn't have taken her into the operating room. We would have referred her for hematology and oncology consults and hopefully gotten her into a treatment plan that could have saved her life. But our hospital leadership said, no, you cannot admit you made a mistake. If you admit you made a mistake, the family will take us to court. The newspapers will get a hold of the story and it'll be published and will look horrible. We must defend it and act like we did everything correctly. And you can understand that 3 years later, the newspapers got a hold of it. We were sued in courts, and in the United States, those could be pretty serious lawsuits with financial retribution. And most importantly, it destroyed a lot of our culture. People said, if this is the type of hospital we're working for that lies and doesn't share and apologize when things go wrong, I'm not sure if I want to work here anymore. But fortunately, we used that story in that case to grow. Now, that's not just, as I mentioned, a one-time off story. Not only does it happen in the United States, but here's a story about Joshua Titcomb, written by his dad, James. This is a story of a number of medical errors that unfortunately took the life of his newborn child within the first 10, 15 days of life. But what made it even worse is the hospital tried covering it up. The hospital and the system just lied about it, and it became a national inquiry within the United Kingdom. And finally, the story came out and caused change within the UK system. This is a documentary, an award-winning documentary, and if you have access to HBO, I'd encourage you to watch it. The title is Bleed Out. It's the story of Judy Burroughs, and Steve Burroughs is the producer. He was the son, and Margot Burroughs, the daughter of Judy Burroughs, who died from multiple medical errors at a hospital in Wisconsin here in the United States. And during the whole process, he was keeping records and keeping track of what was going on and all the, not only poor care she received, but the lying and cover up afterwards. And it's an amazing documentary film. Like I said, it's won a number of awards, but it just shows that the healthcare system as a whole does make mistakes, and we've got to learn and improve, but then many times tries to cover these things up. And it's quite embarrassing for all of us in healthcare when these stories come out. So we looked at ourselves and we basically said, we had met the enemy and he is us. If we are going to change, if we are going to improve, we've got to go at it from a different way. And in 2003, 2004, this book came out, and many of us at the University of Illinois, where I was practicing and helping lead quality and safety at the time, read the book. It's by Rosemary Gibson. It's called Wall of Silence. The book is a story of 75 different patients or families that were unintentionally harmed by medical care. And the book does not go into what deeply happened, or root cause analysis, or event reviews, but the book concentrates on interviews with the patients and family members on what they wanted from their health system after harm had occurred. And it became almost 100%, complete that they wanted 4 things. First, they wanted the truth. Tell us the truth. Don't lie to us. Don't sugarcoat it. Don't try to keep certain things secret. Answer our questions truthfully and honestly as much as you know. Second, if an apology is appropriate, if the care was substandard, apologize for that care. Third, they wanted to know, what are you going to do to help remediate our loss? What is the remedy? How are we going to be taken care of so we could go on without our father, without our spouse? And finally, everyone to a person, and I've seen this through my 30 plus years of doing work in quality and safety, they all wanted to know what the hospital or health system was going to do to improve the quality of care so that no one would lose their life or be harmed in a similar fashion. And we read this book and we said, we've got to try a new approach, because clearly lying about medical errors wasn't working. We were getting worse. We weren't getting better. So we decided, what would it take to change our model? And we said it would take courage and support of our leadership. And so we set out on a mission to try to change the way we practice at the University of Illinois back in 2003, 2004. And Makia, I'll let you take the second poll question right now.
Sure, Doctor. Now we are launching the second question. Which of the following countries has not implemented a formal CANDOR program? A, Mexico, B, Australia, C, United States, D, Ireland.
Give it a few more seconds. Looks like we've got a lot of responses now. The correct answer is A, Mexico. Mexico, while talking about CANDOR, and you'll see, I'll talk about the programs that Australia, the United States, and Ireland have adopted around open and honest communication after harm. Now let's see if I got to do this again. Yeah, just locking it up. There we go. I'm sorry about that, these technical glitches, but we'll get through it. We got one more question and poll to do. So first, let's talk about the United States and how our particular university, the University of Illinois Medical Center in Chicago, responded after we missed those blood tests and the women died from leukemia. We took what was called the 7 Pillars program. And basically what this was the ability to be open and honest after preventable medical harm, the ability to have these conversations with patients and families, the ability to use transparency to learn from the events, and to provide a remedy and closure to the families of those that were harmed. And this became a very well-known program in the United States. We started it back in 2004, 2005, and then we published these results about the 7 Pillars program. Well, that program led to our Agency for Healthcare Research and Quality funding more research on that approaches like the 7 Pillars. And there were a few other hospitals within the United States that were doing similar work. So we all came together and implemented additional research that led to what we call the CANDOR, or Communication and Optimal Resolution Program, here in the United States. As I mentioned, it was funded by the AHRQ, and they created a whole implementation toolkit. So if you go to the AHRQ's website and in the search box type in CANDOR, you will find this whole toolkit of resources, how-tos, things that you could use immediately to start learning about and start implementing a program like this. And the concept, the really foundation behind this program is what's called an immediate response to patient harm, or what we took from the National Transportation Safety Bureau here in the United States, the idea of a go team, that we immediately respond when we have these type of events. We don't wait for 2, 3, or 4 weeks when it's convenient to get together, but we start trying to understand what happened immediately. And we have 3 different go teams. One is to find out what happened. That's our event review go team. The second is we start communicating with our patients and family members immediately. Many times we don't know what happened immediately, but we tell them we're going to find out. And as we find and learn things, we're going to share with you. And then finally, we have a care for the caregiver go team, because no one goes to work and hopes to harm somebody while they're trying to cure them, heal them, take care of them. And so we found that our staff, our health workforce is devastated also, and we try to support them. Well, here's a number of different things that are going on around the country. And I thought this was very impressive. Adrienne Cullen was somebody who was affected by a preventable medical harm. She had a lengthy delay in diagnosis when biopsy results and specimens weren't read effectively and then communicated those results. And 6-8 months went by without treatment. She eventually died from her cancer. But the university and the government said they wanted her to have the opportunity to share her story, and the doctor to also share his story, so they could all learn from it. And this was on TV, it was broadcast and recorded. It was an amazing event, very compassionate, very empathetic. And again, it allowed others to learn from the mistakes that were made in Adrienne's care. Australia has been very active in CANDOR type programs. And as you can see, their disclosure framework says we must have an open discussion or series of discussions, because many times these conversations are more than just one conversation and then we're done. We always say that these conversations continue until the patient or family member says, we're done, we don't need any more explanation. But it's an open discussion with a patient and their support person, if necessary, about a patient safety incident which could have resulted or did result in harm to the patient while they were receiving care. The territory of New South Wales takes it even deeper. Their Clinical Excellence Commission has been doing a lot of work and research into disclosure programs going back into 2005, 2006. And they also support these conversations of honest, empathic, and timely discussions between care team members and patients and families after a safety incident. In Ireland, they have established what they call the duty of candor. When things go wrong, the professional duty of candor was developed in collaboration with the Nursing and Midwife Council. It imposes on doctors, nurses, and midwives a professional duty to be open and honest with patients when things go wrong. So you could see, not only have we seen these programs starting up in countries around the world, but more and more of them are starting to look at, how do we do this and why do we do this? Well, we do it because it's proven that we can make care safer by learning and being open and honest. And again, I referred to, we use this analogy. This is many, many years ago, the Asiana airline incident at the San Francisco airport here in the United States. And what the team did is they didn't wait for 2-3 weeks to go visit the site. They immediately went to San Francisco and started learning about what might have happened. The longer we wait, the less people remember about what might have happened, and our data and our information gets weaker the longer we wait. So with the CANDOR Toolkit, we embrace what we call a serious unanticipated outcome go team. In that when we have an event where something went in a direction that we didn't expect it, care changed dramatically, and we don't know why it changed, and the patient is now suffering, we don't know if somebody made an error or this was just healthcare. We know we can't save everybody. We can't cure every disease. But if something went in a direction we had anticipated, we have to act and find out why. Because if we're confused, we know the patient's family's confused. So we adopted what we call the Patient and Family Communication Go Team, as I mentioned earlier. This is a group of trained individuals within our health system. It could be physicians, nurses, pharmacists. It could be allied health. It could be whoever wants to be part of these teams. And they go and start having conversations with the patient or family members. And like I said, some of the first conversations are, we don't know what happened, but we're going to find out. We're going to answer your questions. And as soon as we learn something, we will share that with you. And we stay in contact. Sometimes, as you know, it could take 3 to 4 weeks to figure out what might have happened. Sometimes we need an autopsy to help us. But during that time, we're staying in conversation and communication with the patient and family members, so they know we're taking these things very seriously. At the core of the CANDOR Toolkit is a system-focused event review process document. And again, you could get, this is a 43-page document that's free to anybody that goes to the AHRQ website. You can download it. And the great thing about this event review or root cause analysis document is not only does it give you a really sound approach on how to do event reviews around medical preventable harm events, but it's anchored in human factors engineering mindsets. We brought together human factors experts. We brought together people from aviation. We brought together patient safety experts and looked at the literature. They reviewed hundreds of articles and took away best practices on how to do these event reviews or root cause analysis after the event. And it talks about, again, immediate response, have a team of people who could interview without feeling threatening, learn as much as you can, and try to finish these reviews within 28 to 30 days. So those action items that come from the reviews, we can start implementing to make our system safer. And I include this article because I think many times, and ourselves included, before we really sat down and tried to figure out how to do a good event review, we didn't give it the attention it needed. This was an article published by our human factors engineers, and they went and looked at root cause analysis done by 3 of the largest health systems in the United States. And they evaluated what were the outcomes that came from those root cause analysis. And again, because of time, because of lack of interest, because of lack of focus, people did these event reviews or root cause analysis very quickly. And they came up with, over 90% of the time, the recommendations were to either re-educate, retrain, or create a new policy. And we know from work in safety and quality, these things either don't work or aren't sustainable. We could put another policy in a book and put the book in the shelf and nobody will remember it months later. We could re-educate people, but then that wanes, and 6 months, 8 months later, new people come on. And so remediation, again, doesn't work because these are system and process mistakes almost 99% of the time. So that was the reason we said we've got to come up with a good event review process that we follow all the time. So you've heard me talk a lot about human factors and the importance of it. And so I say, why do we need human factors in healthcare? Well, I show this photo. It's something we see in the United States because here we pump our own gas, and we go into a gas station and we put the hose into the gas tank and we pump our gas. And yet many times we forget to take the gas hose out of the tank and put it back in the pump. And there is a website that has over 1,000 pictures of cars in the United States driving down the street with gas hoses hanging out of their tanks. And I guarantee you, these people did not go into the gas station that day and say, I am going to drive away with the gas station owner's, hose to the gas tank. They made a mistake. They got occupied with something else. Their mind was not thinking. Whatever it was, they made a mistake. James Reason, who many believe is the father of safety science, has said, we cannot change the human condition, but we can change the conditions under which humans work. That gas station could have put signs on the gas tank saying, please don't drive away with our gas hoses, but that wouldn't have helped. People still would have done it. So they put safety traps in place so that if somebody does drive away with a gas hose attached to still in their tank, there's a separation valve that keeps gas from leaking onto the concrete in the gas station area. So you try to put in systems and processes that say, we know humans are going to make a mistake. It's inevitable. So how do we trap those mistakes and change the conditions so that when they do make the mistake, no one gets harmed? I'll give you a couple other examples. Here's a door. This is from a restaurant in Washington, D.C. And a good friend of mine, Terry Fairbanks, who used to run our Human Factors Center and now took over my position in leading operational quality and safety at MedStar Health, sat at the door for an hour and watched people going out the door. And he said that over the hour period, 2 of every 3 people would go up to the door and pull the door handle trying to get out of the restaurant. They would pull the door handle even though a sign right in front of their eyes said push. And you know what happens when you pull the door handle? It doesn't go the opposite way and you kind of stagger back and then you go, oh, I need to push it. Well, our mental model is we see a handle, we want to pull it. We see a pad on the door, we want to push it. This is a great example of how human factors sets us up, or a lack of human factors mindset sets us up to make a mistake. Here, no one gets hurt. We're just pulling a handle that won't allow us to open the door that way. And we feel like we made a mistake. We feel foolish, but we push the door and we leave. But here's another example that Terry studied and published. And this does harm patients because of human factors. So here's a defibrillator. This is a piece of equipment we use a lot in our hospitals. In the morning, we set it up, we make sure it's ready. And in case we have any sort of cardiac arrest within our hospitals, We grab the defibrillator, the code team goes into the room. The leader says, okay, you know, we get ready to defibrillate the patient. The on button is on, you hit energy select, you hit charge, and then the leader goes, asks everybody to step back before they're going to defibrillate the patient. Well, even though that doctor, that nurse, whoever's running that cardiac arrest has used this piece of equipment for 30, 40, 50 times, 1 out of every 5 times, the person, when they go to set the charge off, they inadvertently, in the craziness of the time of the cardiac arrest, they hit the green button. Mental model, green, go, red, don't go, danger. And so when they hit the green button, what happens? The defibrillator turns off. And now they panic. They go, oh my God, I didn't mean to hit the green button. I wanted to hit the red button. So they hit the green button again to turn it on. Well, it's a computer. And a computer takes about 2 minutes to reboot itself and get ready before we could select the energy, charge it, and now give the correct shot. That's 2 and 2.5 minutes roughly of wasted time. And we know at the cardiac arrest, the time to defibrillation is critical. If we could do that within 3 to 5 minutes, the chance of saving a patient's life is much greater. And yet, because of a human factors issue, because of a common mistake made by our mental models, we lost that 2.5 minute window that could have saved this patient's life. And just, it's a shame. So we don't make equipment today. We're getting better, but a lot of our equipment hasn't been designed with a human factors mindset. And I show you this. We've got these, projectors that we use for when we were all together and giving talks. But even these simple pieces of equipment, if I were to hit the button on that machine by mistake, if I wanted to refocus my slides, my presentation, and by mistake, I hit the on-off button, a prompt comes up and says, are you sure you want to turn me off? And if I do, I'd hit the button again, but because it was a mistake, I'd say no, and the machine stays on. Why don't we in healthcare have those sort of fail-safe systems, have those human factor traps that will prevent me from hitting the wrong button at a crucial time? We need to do more work in that area. And this is why we need to look at it. So we put our coworkers in unbelievable conditions. We put them in rooms like this that have multiple pumps, multiple infusions, different pieces of equipment. And then we tell them, don't make a mistake, be safe. And this is what happened. They make a mistake and they feel terrible. Okay, Makia, let's try it one more time. We could put the poll question up, the third and last one.
Okay, Doctor, moving to the third. According to many safety leaders, the single greatest impediment to medical error reduction is few people care about patient safety, lack of effective leadership, punishment of people who make a mistake.
Give it a few more seconds.
Sure.
Okay, so great answers. And all three of these, there are examples of where, they do have an impact on error reduction. We need to get more people to care about patient safety. We need people to take notice of it and understand the issues. We also need to make sure we've got effective leadership. And many times we do have tremendous leadership. But a lot of people today feel that what we've done in the past of punishing people for making mistakes, the idea that we're all humans. There's so many examples. I've made mistakes at the front line of care. And we don't do it intentionally, but if we punish people for making those errors, what happens is they just don't talk about the errors anymore. Others within the organization see that if I were to share this from a learning opportunity, we're going to punish me, and I don't want to be punished, so I'll keep quiet. So more of the current thinking today is about, well, we do need effective leadership. We do need to raise awareness and get more people engaged in patient safety. We've got to stop punishing people and bring a different philosophy to shared learning and improvement and support many of those people who unfortunately made an error that they hadn't expected to make or didn't want to make. So let's see if we got to do this one more time and get through. Yep, I'm going to have to stop sharing and just go back. And this is why I talk about punishing people. Good people come to work trying to heal and do well. And if we're in a situation where we make a mistake unintentionally, you know, so many things happen within an environment, we feel horrible. And this is just one example we've seen here in the States where a nurse took her own life because she wasn't supported. People felt that she had made a mistake that any one of us might have made, put in the similar situation that she made. And it caused the baby to get too much of a medication. The baby was a very sick baby with multiple congenital issues and might not have survived anyways, but the medication mistake did cause the baby to die. And the hospital did not support the nurse and ended up, the nurse took her own life. And we've seen multiple examples of the reason of what we call you need to have a just culture. And so what is a just culture? This is the Lucian Leaf. Many of you know Lucian. What a wonderful gentleman. He's been recognized, at least here in the States, as, you know, the father of patient safety, and it spoke all over the world for the WHO and other organizations trying to make care safer. He's been a great friend and mentor. But he, like others, emphasizes that the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes that unfortunately at times are just the way we are as humans. And you've heard me talk about mistakes. I probably make 10 mistakes a day inadvertently in things because I'm multitasking, I'm not paying attention. I think I set the coffee maker correctly and I didn't. Stuff like that goes on, and we've got to figure out how to make our systems and processes better. Just culture is an important part of CANDOR and an important part of a safety culture. And there's a number of people who've written about this. James Reasons, I mentioned him earlier, David Marks, but I really like Sidney Dekker. He's from Australia. He's an aviation expert. He's just understands healthcare and really gets the concept of just culture. And Sidney Dekker says just culture is the balance between the science of safety and accountability. He questions and he says, we must ask what is responsible, not who is responsible. The aim of safety work is not to judge people for not doing things safely, but to try to understand why it made sense for people to do what they did. If it made sense to them, it will for others too. And again, in my roles of leading quality and safety for a large health system, as well as my work back at the University of Illinois, there were many times where I got that first phone call. I got the call from the doctor, the nurse, whoever, that said, we just had an error that was made, and here's what happened to this patient. And I get off the phone and say, okay, I'll be right up, and we'll start figuring out what happened. But sometimes the first reaction I have is, how could that have happened? How could anybody have made that mistake? And then as I slowly step back and say, wait a minute, let me go there, let me hear what happened. and I listen to the thinking. I hear what the people at the front lines were doing and what was going on. And I would always say to myself afterwards, you know, if I was in the same situation that physician, that nurse was in at the time, I probably would have done the same thing. I would have made the same decision to do what they did, even though I know now it was wrong. But with the information they had and the situation in front of them, they were doing what they thought was right, even though it led to a mistake that caused preventable medical harm. So we've got to show our people that we're not going to punish them. We want to learn and we want to improve our systems so that we can make them better. That said, as Decker calls out so correctly, we can't just blame systems and processes for everything. We've got to hold people accountable. And if somebody was knowingly and violating safe practices, if they just said, you know what, I know this is the correct way of putting a central line in, but I'm not going to do it. I'm going to do it my way. And I don't care what the evidence and what our protocols and policies say. And then somebody gets harmed, then they need to be held accountable, because we've got to follow the evidence and do what we all believe is the correct way. And so accountability is so fundamental to human relationships. And as Decker says, if we don't hold the people accountable at times where they should be held accountable, then our systems become almost anarchic. We could do whatever we want without having any oversight of accountability. So we've got to trust the science of safety and learn from these events and know that people need to understand and be trained to have better processes and systems in place, but we've got to hold people accountable. So I encourage you to read, from Sidney Decker. His books are short, they're very easy reads, and they have a lot of wonderful information. So Nikki, I'll stop there and give us time and thank everybody for spending the time with me to hear thoughts about CANDOR and how it can improve your culture of safety.
Thank you so much, Doctor, for a very informative lectures, really. And I myself enjoy this tool, and it was my pleasure really to be moderating this session. So our participant, if you have any questions, you can just share it with Q&A button. And Dr. Dave will be answering them soon. I got one, Doctor.
Sure.
There's one question that from our participant saying that her organization started to implement disclosure toolkit for healthcare providers. Do you recommend that she can come up with another toolkit for patient and community as a campaign for this toolkit?
Sure. I mean, I would recommend, first of all, when I showed that slide about it takes courage and it takes leadership, this is not the type of program that you want to implement from the ground up. If you don't have full support from your leadership, you're going to find yourself sort of out alone and maybe reprimanded for doing what you believe is right, but not having leadership. So when we started implementing our program at the University of Illinois, as well as it's embraced at MedStar Health, where I work now, we made sure we had our leadership's approval to do the right thing after harm. And they did. Both organizations I fortunately worked for embraced it and said, you got to do this. And so they knew what we were doing when harm occurred, and they were fully supportive of being open and honest. Now, I mentioned the CANDOR Toolkit on the AHRQ website. It's a great resource, but I think what you got to do is you got to go to it, download it, go through it, and find out what areas would work best in your health system, in your culture, in your environment. A lot of hospitals here in the United States have started implementing. There's 5 different components to the CANDOR Toolkit. And what they've been doing is they'll start off with one of the components and say, okay, let's start off with the Care for the Caregiver program first. and then they roll that out. And then they say, okay, let's now look at this event review go-team model, and let's roll that out and implement it. Now let's figure out how we communicate open and honestly with our patients and families once we've done those great event reviews. So hopefully that was the answer they were looking for, but you've got to really make it specific to your culture, your environment, as well as making sure you have leadership approval and buy-in for you to start rolling this program out.
That's great. Thank you, Doctor, for answering. Another question from our colleagues saying, what are the quick actions that leaders can put in place to foster the just culture?
That's a great question. I think a lot of it is around the high reliability tools I talked about, getting leadership to embrace high reliability and resilience science, to understand first what it is, and then to embrace it and to lead through it. So when I first got to MedStar in 2012, that was the first thing I worked with our leadership to roll out, was high reliability for leaders. And so what does that mean? A couple examples that are part of those tools and techniques of high reliability. It's that leaders start every meeting with a safety moment. That's one of the tools of high reliability. So I asked all our leaders to, before our finance meeting, before our marketing meeting, before our board meetings, whatever it was, our senior management meeting, we would take 60 to 90 seconds and do a safety moment. And a safety moment is just a short story about something that maybe went well, what we call a good catch, somebody on our floor or somebody for a patient stopped the line, so to speak, and prevented a patient from getting harmed. We like to share those stories and celebrate them. A safety moment is also something that didn't go right, and that's something that we need to learn from and improve is shared. But it just grounds people at the meetings that no matter what your job is within a health system, safety is our number one priority. And so if we start every meeting with a safety moment, it reminds people that we are a high reliability organization and we are focused on safety. The second thing is leadership walk rounds, getting leadership out of their offices and to walk the floors, to talk to physicians, nurses, pharmacists, allied health, whoever it is, talk to security, talk to escort service, and just ask them, did you see anything today that was a safety issue? What could I do to engage or to do something that would make this floor, this unit safer? And it's quick conversations with people. Once they see leadership on the floor, taking things seriously and asking questions, it becomes contagious and others want to adopt it. So I think, to me, that's one of the best ways to get your leadership involved in safety and high reliability and leading as safety as an example.
That was great recommendation, Doctor. Thank you so much. Actually, another last questions. Moving to virtual care, is there any update for CANDOR Toolkit that you could just share with us?
On virtual care?
Yeah.
Yeah. Look, the pandemic, as we all know, has made things challenging, and telehealth and virtual care has created some great effective ways of connecting with our patients and family members during these challenging times. But it's also created some issues of learning and how to make sure that we are effectively communicating. The CANDOR Toolkit is not looked at any changes within a virtual environment, but I could tell you many of, even before the pandemic, while we tried to do all our conversations and discussions and question and answer sessions with patients and families real time in the hospital or in an office and sharing that, many times we had to do it through a telehealth platform because it was inconvenient for them to come back to the hospital. They had already been discharged, but we were still trying to figure out what was going on. So we do it through a group call or a virtual platform type of conversation, but we wanted it to continue that way. But there's nothing specific in the CANDOR toolkit that discusses the idea of virtual care.
Awesome. Thank you so much, Doctor. We are ending this session by the last questions. On behalf of Saudi Patient Safety Center, we would like to thank you, Dr. David Meyer, and the audience for their active participation. And as a part of Saudi's Patient Safety Center efforts to provide you with the timely topics and interesting speakers, we would like to appreciate if you could fill the evaluation survey, which will be sent to you by email. Thank you for joining us today, and we look forward to welcoming you back in the future webinars. Thank you all. Thank you, Doctor, and the last call is for you.
And stay safe and good luck. And we applaud everything you're doing at the front lines during these challenging times.
Thank you, Doctor.